Welcome to this short podcast looking at the science behind chemical respiratory allergy and occupational asthma, focusing in particular on the challenges and the new opportunities for the identification of true respiratory sensitizers. I'm Fiona Smith, a product safety specialist from industry and within the methacrylate regulatory and toxicology group involved in the harmonised classification and labelling activity on methyl methacrylate within Europe. I'm joined here today by Professor Dr. Ian Kimber, a renowned immunologist from the University of Manchester in the UK. Professor Kimber has worked extensively on respiratory sensitisation over many years and has published on methyl methacrylate and the proposal to classify it as a respiratory sensitizer. Welcome, Professor Kimber.
Thank you.
Professor Kimber, as a general introduction, can you provide some background to chemical respiratory allergy and the challenges associated with the identification of respiratory sensitizers?
Yes, thank you. Chemical respiratory allergy describes the ability of some chemicals to cause allergic sensitization of the respiratory tract and occupational asthma. Examples of classes of chemicals that do this include the diisocyanates, such as toluene diisocyanate, and acid anhydrides, such as trimolitic anhydride. It's interesting that the number of chemicals that have been shown definitively to cause respiratory sensitization is probably no more than 50. And this contrasts starkly with the situation of allergic contact dermatitis, where more than 2,000 chemicals have been shown to cause skin sensitization. The sensitization of the respiratory tract is a difficult area, both immunologically and toxicologically. And one of the reasons for that is that there are still no dedicated or fully validated animal tests for identifying which chemicals cause respiratory sensitization. But there's still a need, of course, to identify respiratory allergens. And as a consequence, we rely heavily on clinical data and also looking at structural homology between the chemical of interest and known respiratory allergens. When we look at the clinical data, the test of choice is the specific inhalation challenge test, or SIC test. And this is regarded by clinicians as being the gold standard for identification of respiratory sensitizers. However, it must be acknowledged that the SIC test, as performed currently, rarely distinguishes clearly between true respiratory allergy and non-immunological mechanisms, such as respiratory irritation. So it's by no means a perfect test in terms of identification of true respiratory allergens. Also, a specific concern is that current criteria and guidelines for the conduct and interpretation of SIC tests indicates that reactions triggered by methods should have the characteristics of an immunological reaction, but without the need to demonstrate exactly what that immunological mechanism is. And inevitably, this has led to confusion and resulted in SIC-induced bronchial reactions due to non-specific irritation, sometimes being misrepresented as allergic reactions. So currently, the diagnostic procedures combined with clinical history, pulmonary function studies, and clinical tests don't always reliably distinguish between sensitizer-induced bronchial reactions and non-specific irritation.
So a lot of complexities. And given that background, are there any solutions in sight?
Well, things are changing. There are now some immunological tests emerging, which I think can help us identify which chemicals are true respiratory allergens. I have to emphasize, however, that there are no fully validated tests for respiratory sensitization, but nevertheless progress has been made. And one of the things that's happened in recent years has been several groups have worked on defining what the adverse outcome pathway is for the development of respiratory sensitization. Adverse outcome pathways, or AOPs, are toxicological tools for determining what happens between first exposure to a chemical and the subsequent development of an adverse health effect. So here we're talking about what happens on first exposure to a respiratory sensitizer, what events take place in the pathway leading to the development of respiratory sensitization. And those AOPs have also translated into the development of new methods for identifying which chemicals cause respiratory allergy. And what I need to do is just sort of take a moment to look at the immunology of respiratory sensitization. And the key players here are what are known as Th2 lymphocytes. Th2 lymphocytes have been associated with the development of respiratory allergy. That is, they're the class of T lymphocyte that allows a chemical to cause respiratory sensitization. And what we've been able to do using the adverse outcome pathways to identify some of the key events following exposure to the chemical and the development of Th2 type responses. And there's three key events which have been identified. The first key event is the interaction of the chemical with amino acids in a selective way. The second is the elicitation of cytokines, which are necessary to support the development of respiratory sensitization. And the third key event, key K3, is the activation of dendritic cells. Dendritic cells are the cells that present antigen to T lymphocytes and stimulate the immune response. So we've identified three key events in the adverse outcome pathway leading to respiratory sensitization. And assays have now been developed to look at the behavior of chemicals with respect to each of those three key events in the adverse outcome pathway.
So that sounds very promising developments with the science. Can you describe how these might be used in practice, or in particular in the case of methyl methacrylate?
Yeah, I think it's interesting because methyl methacrylate, there's been a lot of discussion about whether methyl methacrylate really is a respiratory allergen or not. And the evidence for is really based on specific inhalation challenge test, SICT test conducted in humans. However, as we just discussed, these are imperfect tests in terms of reliably determining whether a chemical is a true respiratory allergen or is inducing respiratory responses due to other mechanisms such as irritation. And therefore, we have to look at other methods to look at whether MMA truly is a respiratory allergen or not. And there are now tests available which allow us to determine whether methyl methacrylate actually triggers the key events which we know are necessary to develop sensitization through the adverse outcome pathway. And maybe I'll just run through those briefly. So you'll recall that there's three key events that have been identified leading to the development of respiratory sensitization. The first of those key events is the selective association of a chemical with amino acid residues. This association is necessary because the immune system will not recognize the chemical on its own. It has to be attached to an amino acid or protein. And we know that for the development of Th2 type responses, which characterize respiratory sensitization, chemicals have to selectively interact with lysine residues. Now, several experiments have been undertaken based on methods developed at the Helmholtz Institute in Leipzig, which has shown that MMA does not selectively bind to lysine residues. So the results of those tests suggest that MMA is incapable of selectively interacting with lysine residues, which is inconsistent with being a respiratory allergen. So the second test method is based on the second key event in the adverse outcome pathway, and this is selective cytokine responses. And an international collaboration between laboratories in Europe and US has developed a method based on the use of precision cut lung slices. And this allows us to monitor whether chemicals will induce cytokine responses that are characteristic of respiratory sensitization. Now, one of the cytokines that we know is required for the development of the sensitization of the respiratory tract is interleukin-1 alpha or IL-1 alpha. And it's been shown in several independent laboratories that, in fact, MMA does not induce IL-1 alpha. So again, we see MMA failing to induce a response in the adverse outcome pathway that is necessary for respiratory sensitization. And the third key event in the pathway is the activation of dendritic cells. Now, a recent international collaboration led by a laboratory in Luxembourg has come up with a model called ALLYSense. And this is a complicated three-dimensional co-culture that provides an alveolar model that reflects the composition of alveolar tissue in the human lung. And ALLYSense is used to identify chemical respiratory sensitizers and distinguish them from non-sensitizers and skin sensitizers as a function of their ability to induce markers necessary to activate dendritic cells to stimulate Th2 lymphocyte responses. And one of the markers they've been interested in is something called thymic stromal lymphopoietin receptor, TSLPR. And this is identified as being necessary for the activation of Th2 lymphocytes by dendritic cells, and MMA fails to induce this. So although these methods aren't validated, when you look at the weight of evidence, then MMA clearly appears to be inconsistent with something that is going to induce sensitization of the respiratory tract.
And that's significant development in the science and encouraging in terms of the evidence. Is there any other experimental evidence that you feel might be of value or of interest?
Well, there's one other piece of evidence that is interesting, and this comes from the local lymph node assay, or LLNA. And this is a method that was developed some years ago for the identification of chemicals that cause sensitization of the skin and allergic contact dermatitis. Now, when this test is based on the ability of chemicals when painted on the skin, the ears of mice, to induce lymphocyte proliferative responses in draining lymph nodes. And skin sensitizers do this. But in addition, it's been found that respiratory sensitizers also cause these proliferative responses, which is perhaps not surprising because they're immunogenic, they're capable of stimulating an immune response. And it's become clear that all known respiratory allergens are actually positive in the local lymph node assay. MMA isn't. It only induces very weak responses or even no responses in the local lymph node assay, which is clearly different to what we see with known respiratory allergens like the isocyanates and acid anhydride. So MMA is behaving differently. We think this provides corroborative evidence that MMA lacks the immunological characteristics necessary to drive a respiratory sensitizing response.
So considering all the available information and the new information, what's the overall conclusion that you draw from these data regarding MMA?
Well, I think when one considers the behavior of MMA in the NAM tests and other experimental animal data, then the weight of evidence argument is MMA doesn't possess the properties, immunological properties necessary to cause respiratory sensitization. And I think it's therefore inappropriate to classify it as a respiratory allergen. It just doesn't have the immunological properties, the immunological wherewithal to stimulate the type of response necessary for effective sensitization of the respiratory tract.
Many thanks for that interesting overview and your thoughts. Would you have any final comments?
Well, I think the two take-home messages for me would be that the studies we've conducted or been conducted with MMA illustrate that there's now available immunological methods, albeit not yet validated, that can inform whether a chemical has the potential or not to induce respiratory sensitization of the respiratory tract. And I think it behoves us to use those methods. It's important that those methods are applied and the data they generate are included in a holistic weight of evidence framework in which all lines of evidence are included, weighted for reliability. And I think then we'll have an opportunity to have a much more robust and much more accurate assessment of the presence or absence of respiratory sensitization potential. So I think what we've done, what we've seen with MMA, maybe paves the way for a more generic approach to look at the respiratory sensitization potential of other chemicals.
Professor Kimber, thank you very much for your time and your insight into this complex topic.
Thank you.